Hello everyone, welcome to our Next Generation NCLEX-RN review session. Today we're diving into an unfolding case scenario on Myasthenia gravis designed to sharpen your clinical judgment skills using the NCLEX-PN's Clinical Judgment Measurement Model Framework. And we'll walk through a series of test items to help you master critical concepts like respiratory management and medication safety. So let's get started and prepare you to ace the NCLEX with confidence.
Before moving ahead, here's something you need to hear. If you're feeling anxious about passing the NCLEX, especially if you're aiming to do it in 1 week or 1 month, then our complete online NCLEX review crash course is your answer. This is your shortcut to success, a tried and tested course with a 99% passing rate. More than 5,000 students have achieved their NCLEX goals using this course, and now it's your turn. Here's what's included. 100-hour animated mini crash course, perfect for last-minute preparation to pass in just 1 week. 300-hour comprehensive lectures covering 300 high-yield topics that the NCLEX loves to test. 5,000 real NCLEX questions. Train with real exam-style questions and be prepared for anything. 15 full-length practice tests, including CAT simulation. Build your confidence with realistic exam experiences. Exclusive NCLEX ebook and 1-year access. Study whenever you need without restrictions. Don't let this opportunity slip away. Enroll now at 70% off. Visit our website to enroll in our complete NCLEX review crash course. The link is in the description. Now, let's jump into the topic.
Here's our first test item. We have a matrix multiple choice, and the case is here. It says a 45-year-old female presents to the emergency department at 8 a.m. with a 2-day history of increasing muscle weakness, difficulty swallowing, slurred speech, drooping eyelids, and double vision. Worse in the evening. She reports fatigue, shortness of breath with exertion, and anxiety about her worsening symptoms. She denies fever or chest pain, but notes her husband is concerned about her ability to manage at home. She has been non-compliant with pyridostigmine due to gastrointestinal side effects. The admission data includes the chief complaint information. There's worsening Myasthenia gravis symptoms, suspected exacerbation, arrived around 8 in the morning, accompanied by a husband. The initial complaint was about muscle weakness, dysphagia, slurred speech, ptosis, diplopia, and fatigue. No pain reported. The initial interventions were oxygen 2 liters per minute via nasal cannula, IV axis placement, and neurological assessment. Let's move on to our next medical record information. We have the medical history. Patient does not have any known allergies. The Myasthenia gravis was diagnosed 2 years ago. She also has hypothyroidism, no surgical history known, and the medications prescribed were pyridostigmine 60 milligrams every 6 hours, non-compliant, and levothyroxine 100 micrograms daily. And she is non-smoker, occasional alcohol, works as a teacher, and her mother has a history of rheumatoid arthritis. Next here we have her laboratory results that came back at 8 in the morning. She is positive for the acetylcholine receptor antibody, the creatinine level of 0.9, potassium of 4, sodium 139, blood glucose 110, white blood cell count looks within normal range here. And we also have the neurological exam as part of the diagnostic test. She has bilateral ptosis, diplopia on lateral gaze, weak grip strength 3 out of 5, dysphagia noted, speech slurred, chest X-ray showed clear lungs, no thymoma identified, and the pulmonary function test with the PFT, it showed forced vital capacity of 2.8 liters or 70% predicted. It indicates reduced respiratory muscle strength. And the electromyography or the EMG is pending, ordered to confirm the Myasthenia gravis exacerbation. Now let's get into the rest of the information here. The nurse's progress notes in the ED. A patient arrived in ED with worsening myasthenia gravis symptoms, muscle weakness, dysphagia, slurred speech, ptosis, diplopia, vital signs, blood pressure 130/82, heart rate 88, respirations 20, saturation 94 in room air, improved to 97% on 2 liters per minute oxygen. Neurological exam, weak grip 3 out of 5, FVC 2.8, or 70% predicted. Patient expresses anxiety about symptoms. IV access obtained, neurology consulted. So this is a test item that's supposed to test your ability to filter all those nursing actions based on the assessment findings, right? So here, I want you to select one descriptor, either indicated, contraindicated, or irrelevant for each intervention in the matrix. Select only one response per row. Or before we go do that, there's actually the emergency healthcare provider orders. And this was entered at 8:30 in the morning. It says, place and maintain nasogastric tube, confirm placement with radiology per protocol. Administer pyridostigmine 60 milligrams via nasogastric tube. Monitor forced vital capacity every 2 hours. Obtain electromyography. Consult neurology for possible IVIG if no improvement. All right. What do you think would be the answer for the first intervention? It says administer pyridostigmine 60 milligrams via nasogastric tube now. Think about that. The correct answer is indicated. Why is it indicated? This is the first-line treatment for symptomatic control for the myasthenia gravis. And this is classified as a acetylcholinesterase inhibitor, which is going to increase the availability of acetylcholine at the neuromuscular junction, and this will help improve muscle strength. Here in the case scenario, the healthcare provider ordered this med to be given via nasogastric tube, which is appropriate because the patient is experiencing dysphagia, slurred speech, both of which increase the risk of aspiration with oral intake. And adhering to the medical provider's order, this is specific. It has that route to be given as nasogastric tube medication. And the timing also reflects safe and timely nursing practice based on the patient's current presentation. Now, let's move on to our next nursing intervention. It says initiate high flow oxygen at 10 liters per minute via mask. This is contraindicated because the patient's oxygen saturation at 97% on 2 liters via nasal cannula reflects adequate oxygenation without any evidence of hypoxemia. Now, if we are going to increase the supplemental O2 via mask at 10 liters, then that is unnecessary. It could be harmful because excessive oxygen can lead to airway dryness. This will potentially increase the work of breathing and will also cause some discomfort in our patient. And another thing is that over-oxygenation in non-hypoxic patients is a very common NCLEX trap. And the interventions should be tailored to actual clinical need, not just applied reflexively. So you got to be careful here. Now, what about the third intervention? It says prepare for immediate intubation and mechanical ventilation. This is contraindicated. We know that respiratory failure is a risk in myasthenia gravis exacerbation, but this patient currently has a forced vital capacity of 2.8 liters, and that is 70% predicted. And take note about their oxygen saturation of 97% on 2 liters. This indicates adequate respiratory muscle function and gas exchange. Now, if you're curious here about the FVC, all right, again, the patient's result was 2.8 liters, right, or 70% predicted. Now, if we're going to compare it to the normal FVC, usually it is around 80 to 120 of the predicted value. So this will tell us the respiratory muscles and the lung capacity are functioning well. Now, like I have said, with the patient's result of FVC, that's 2.8 to 2.8 liters or 70% predicted. This indicates moderate weakness in the respiratory muscles, which is something that you will expect in a myasthenia gravis exacerbation. But here's the key point. It's not low enough to suggest imminent respiratory failure, because in myasthenia gravis, an FVC above 2 liters is usually considered stable. So the care plan, like monitoring the FVC every 2 hours, makes sense. It will help us detect any decline early and also act quickly if the patient conditions worsen. And intubation at this stage is very premature. It is very invasive. The patient doesn't need it right now. This will expose the patient to unnecessary complications. And I want you to keep this in mind, that intubation should be considered if the FVC drops below 1.0 or 1.5 liters, or if the patient shows signs of hypoventilation, if there's cyanosis or increasing respiratory distress. Let's move on to the next one. Administer lorazepam 1 milligram IV for anxiety. This is contraindicated. Although the patient may understandably be anxious, and remember that lorazepam is a benzodiazepine. It can depress central respiratory drive and muscle tone. And patients with myasthenia gravis who already have compromised neuromuscular function, especially affecting the diaphragm and the intercostal muscles, this could cause or worsen respiratory compromise. Now, at this point, we can probably institute non-pharmacologic measures for that is much safer than the anxiolytics. This is something that you should plan on doing instead of the lorazepam. Now, the next intervention says, place the patient in high Fowler's position. This is indicated. Why is that? Because this can help facilitate diaphragmatic excursion and can help expand the lungs, which will also make their breathing efficient. And we know that in myasthenia gravis, there is respiratory muscle weakness, which is the core concern, and placing them in upright position can support both the ventilation and support safe swallowing. This is a non-invasive, low-risk intervention that will provide symptom relief. It can promote airway protection. It is also aligned with the basic nursing principles of positioning to enhance oxygenation. Now, what about administer prednisone 60 milligrams orally? This is contraindicated. And why is that? Now, prednisone is commonly used in chronic management of myasthenia gravis, and this is an immunosuppressant, but this is not appropriate as an acute unscheduled intervention here. It was not ordered by the provider at this time, and it is also contraindicated because of the patient's dysphagia. Remember, it says here that the medication is ordered orally. Another thing is that high-dose steroids can initially exacerbate myasthenia gravis symptoms. Keep that in mind, because this can increase the muscle weakness in the early phase of treatment, and this risk must be balanced and initiated under controlled conditions, typically frequent monitoring and consultation with a neurology. So if you're administering this dose without an order or without full evaluation by the neurology department, For neurologists, this is unsafe. Now, what about obtain arterial blood gas analysis? This is irrelevant. And why is that? Because the patient's saturation is stable, 97% on 2 liters, respirations somewhat kind of on the borderline, 20 per minute. And ABG analysis is typically indicated if there is an evidence of hypoventilation or oxygen desaturation at the level that is lower than the borderline, or if there is clinical deterioration. Now, in this case, the FVC is being monitored, which is the standard non-invasive measure for respiratory function in this patient. And the arterial blood gas provide redundant information and can also expose the patient to unnecessary discomfort and resource use. That's why it is irrelevant at this point in care. Let's take a look into the next one. Administered diphenhydramine 25 milligrams IV prophylactically. This is also irrelevant. Why is this irrelevant? We know that Benadryl, which is an antihistamine, is given to prevent allergic reactions in cases before we administer some medications. However, at this point, IVIG, which is supposed to be given when the symptoms becomes worse, but it's only mentioned as a potential future intervention, but it's not being ordered yet, and that's why it is irrelevant. Now, what about the administration of pyridostigmine 30 milligrams IV? What do you think about this? This is classified as contraindicated. Why is it contraindicated? Now, considering that this is ordered IV, compared to the first one that we have talked about, pyridostigmine 30 milligrams via nasogastric tube. See the difference in the route? When the pyridostigmine is given IV, there is a higher risk of rapid onset and possible cholinergic crisis. That's why the nasogastric tube route is appropriate, and that's why it is ordered. Now, let's talk a little bit about what to do if the provider ordered the IV pyridostigmine instead. Technically, if the doctor wrote a valid order for IV pyridostigmine, then as nurses, we are expected to follow that order. So it's not prohibited in the legal sense. However, here's the clinical judgment piece. Just because something is ordered, it doesn't mean it's the best option for the patient. And in this scenario, the patient is stable. So going back into the action of the drug, there is a higher preference for giving it through the nasogastric tube. Now, if you, instead of giving the medication IV, this can actually cause sudden spike in the acetylcholine. It can also raise the risk of cholinergic crisis. That's why the safer route is through the nasogastric tube. So remember, for the NCLEX, we follow provider orders. That's correct. But we also need to recognize when a route or intervention might be clinically inappropriate based on the patient's condition and risk factor. So that's where our critical thinking really counts. And lastly, we have coordinate with radiology for abdominal X-ray. What do you think about this? Is this classified as indicated, contraindicated, or irrelevant? The answer is indicated. Why? Because the provider has ordered a nasogastric tube insertion for administering pyridostigmine 60 milligrams. Now, why not give it orally? Yes, because the patient has dysphagia, plus it's going to put them at high risk for aspiration if they take meds by mouth. Now, before we are going to use the nasogastric tube, after it's inserted, what we need to do is to confirm first if it's placed correctly. If not, then we're going to risk serious complications like maybe accidentally administering the medication into the lungs, which could lead to aspiration pneumonia or even pneumothorax. And as nurses, we have a few independent methods to initially check the placement. We can do aspiration of the gastric contents, check the pH, and ideally we are going to want a pH less than 5.5. Another technique, remember that we can also inject the air into the inserted nasogastric tube, and we're going to listen over the stomach for that whooshing sound. But here's the key. These methods are not definitive, and the only way to confirm that the tube is in the stomach is through an abdominal x-ray, and that's why we need to coordinate with the radiology as a collaborative intervention. And according to the American Association of Critical Nurses guidelines, the confirmation of the nasogastric tube placement is going to require radiographic confirmation, especially if we are going to administer medications or if we are using the nasogastric tube for enteral nutrition, right? And from the NCLEX-RN standpoint, this is a perfect example of prioritizing patient safety. We always combine our independent nursing skills with collaborative actions to ensure devices like nasogastric tubes are correctly placed before we use it. And so when you're caring for patients with a nasogastric tube, always remember, check independently first, but you need to confirm definitely with an abdominal x-ray, especially before giving medications or enteral nutrition. Let's move on to our next test item. We have a multiple response grouping, and we have an updated emergency department nurses progress notes. At 10 a.m. it says, patient reports slight improvement in ptosis, but persistent dysphagia and fatigue. Vital signs, blood pressure 128/80. Heart rate 86. Respirations 22. Saturation 96 on 2 liters. FVC decreased to 2.5 liters. So that's 65% predicted. The patient is anxious about hospitalization. Now, we have an updated healthcare provider order at 10 in the morning. It says initiate IV immunoglobulin 0.4 gram per kilo per day for 5 days. And also to continue pyridostigmine 60 milligrams every 6 hours via the nasogastric tube. Now, how are you going to answer this question? I want you to focus on the updated patient status and the new orders to prioritize interventions that manage the symptoms and prepare for the IVIG. Now, for each category, we have the symptom management, IVIG preparation, and monitoring. The task for you is to select the 2 interventions by assessing which directly address the patient's current needs, such as respiratory support or to ensure safe IVIG administration. And don't forget to use the CJMM to analyze the cue strategy and also to differentiate urgent physical symptoms from those less critical ones, and make sure that you prioritize the hypothesis to choose those interventions that prevent complications like, I'm not going to say it right now. All right, so here is your task. Again, select 2 interventions for each category to manage symptoms and prepare for IVIG treatment. Now, let's take a look into the correct answers first. For symptom management, one of the correct answers is to position the patient in high Fowlers. So this is, the patient should be sitting upright at 60 to 90 degrees. This is very critical for a patient with dysphagia and respiratory muscle weakness, all common in myasthenia gravis. Another thing is that by gravity, it will facilitate swallowing and it will decrease the risk of aspiration. Remember that with the myasthenia gravis, even managing their own saliva can be difficult sometimes. So this is a perfect intervention. Now, another correct answer is to encourage deep breathing exercises. This is going to help improve lung expansion. It can also promote alveolar ventilation, prevent atelectasis, can also develop, because these can all develop due to the hypoventilation, right? Now let's move on into the IVIG preparation. What do you think would be the correct answers here? The first one is verify IVIG dose, which is very critical here, because if you're gonna administer an incorrect dose, this can possibly lead to subtherapeutic effects or maybe severe adverse events. This can also cause thromboembolic complications, even renal dysfunction. Now, I've given this medication several times way back as a medical surgical RN in the past. I've done one-to-one patient care whenever I start the infusion, because you're going to be monitoring the patient's neurostatus and overall assessment and vital signs in the whole duration, right, of the treatment. Now, this step actually will help align the right dose component of the 5 rights or the 10 rights of the medication administration, and also considered safety critical task in this case. Now, what else do we need to check off here? Another is to make sure you have patent IV access for the patient, because the medication is administered through IV and this is given as a slow infusion. Make sure that we have a patent line, which is necessary for effective delivery of the drug. Now, IV infiltration or occlusion can lead to treatment. So that's why we're going to make sure that there is good blood return before we start the infusion. Now, what else? We're going to head into the monitoring category. The correct answer here is to monitor FVC every 2 hours. This is a key indicator of respiratory muscle strength in the myasthenia gravis. And I want to emphasize this, that when there is a decline in the FVC, this signals impending respiratory failure and also the need for intubation or intensive care unit care. And that is why critical monitoring of the FVC should be done frequently, especially when we are treating the patient with the IVIG, right? So we can track those changes and we can intervene promptly if there is respiratory compromise or if there is deterioration in the lung function. Now, what else is something that you should select here? We have assess for cholinergic crisis symptoms, which is something that you will expect with excessive dosing of pyridostigmine. And this is going to be manifested by muscle weakness. There's going to be bradycardia. There's going to be meiosis and increased salivation. And since the patient is continuing pyridostigmine therapy, it is very critical for us to differentiate between myasthenic crisis, which is under treatment, and cholinergic crisis, which is caused by over-treatment, both of which may require very different interventions. Now, let's look into the wrong options for the symptom management. One of those is administer ondansetron 4 milligrams IV for nausea. This is not part of our answers because there is no evidence in this scenario that the patient is experiencing nausea and vomiting. So this is not clinically indicated. And remember that when you administer unnecessary medications, there's going to be increased risk of adverse effects. This can possibly cause QT prolongation, which can divert your attention from more pressing respiratory issues. Never get this one if not needed. Next is administer prednisone 60 milligrams orally. We know that corticosteroids like prednisones are used in the long-term management, but this patient has dysphagia, remember? And that's why there was a need for us to insert the nasogastric tube to administer the pyridostigmine through that route, right? Now, let's take a look into the last option of symptom management. Provide reassurance for anxiety. Although psychological support is important, reassurance alone does not address the patient's physical symptoms of fatigue. It does not address dysphagia. It does not address respiratory decline. And interventions that improve the oxygenation and neuromuscular function will take priority here. All right. Now, what else? IV preparation. What do you think are the reasons why we are not selecting administer diphenhydramine 25 milligrams IV? We know that this is used as a pre-medication to prevent infusion-related reactions before we administer IVIG. But here's the key. It is not automatically required and was not ordered by the doctor as well in this case. And if we prematurely administer this without prescription or without any indications or any signs of hypersensitivity risk, this is inappropriate and this could cause unnecessary sedation, especially that the patient already is at risk for respiratory compromise. Now, what about order chest CT? Actually, this is more of like obtaining an order for chest CT to rule out thymoma. Now, here's the key. Thymoma is associated with myasthenia gravis, and chest CT may be appropriate diagnostically, but this is not an immediate preparatory step before we administer the IVIG. Okay, so the CAT scan study is not needed to be completed before initiating the IVIG treatment. All right, so the rest of the answers here. Monitor for infusion-related rash. We know that skin rashes and other infusion reactions can happen when we administer IVIG, but monitoring for a rash is considered post-infusion task. It is important, but it's not part of the preparation phase, and the nurse here should focus on ensuring dose accuracy and IV patency before the infusion starts, rather than anticipating side effects not yet present. Now, for the monitoring category, the rest of the options are incorrect, such as monitoring blood glucose every 4 hours. We know that monitoring is important because patient is taking corticosteroids, but prednisone has not yet been initiated. And we also have check for jugular venous distension. This is also a marker of right-sided heart failure, which is not suggested in the current scenario. And the patient has normal vital signs at the moment, and there's no evidence of cardiac compromise. That's why we're not selecting this. For the last one, monitor for headache post-IVIG. Well, I want you to pay attention here. Headache is a known side effect of IVIG, but this is a post-infusion concern. The nurse should prioritize interventions and monitor that address the acute myasthenia gravis symptoms and respiratory function, which are more immediate threats to the patient's safety. And so this intervention becomes relevant later after the infusion begins. So for this multiple response grouping test item, I want to make sure that you did your analysis of the cues. You have to pay attention to the respiratory weakness, the fatigue, the dysphagia, and the anxiety. These are symptoms of possible myasthenia gravis exacerbation. Make sure that you've done your prioritization of your hypothesis, especially comparing versus the myasthenia gravis crisis or myasthenia crisis versus cholinergic crisis risk, right? So the primary concern here is airway and breathing. Now, lastly, I hope that you didn't miss generating the solutions, making sure that the interventions that you selected target respiratory support, medication safety, and preparation for IVIG with ongoing monitoring to detect any deterioration early. Moving on to our next test item. This is a matrix multiple response. Here's the case scenario. It says in the emergency department nurse's progress notes, at 12 noon, IVIG initiated, pyridostigmine continued, patient reports worsening shortness of breath, new respiratory distress, and anxiety about breathing, vital signs, blood pressure 132/84, heart rate 92, respirations 26, oxygen saturation 92 on 2 liters via nasal cannula, FVC 2.0 liters, that's 50% predicted, crackles noted in the lower lobes bilaterally, ABGs, pH 7.38, partial pressure of the CO2 42, partial pressure of oxygen 85, suspected myasthenic crisis. Now we also have the table for the lab results, so I'm only gonna mention here the potassium level of 3.9, magnesium of 1.8, and in the diagnostic results table, we are seeing that the patient's pulmonary function test with FVC 2.0 and lung auscultation, there are fine crackles in the lower lobes bilaterally, and this suggests possible atelectasis or early pulmonary edema secondary to respiratory muscle fatigue. Now let's move on here. What do you think would be the next? We have the healthcare provider orders at 12 noon. The medical provider stated transfer to ICU, increase oxygen to 4 liters per minute via nasal cannula, consult pulmonology for BiPAP consideration. So here in the instructions, your task is to select all applicable descriptors for each intervention. At least one option must be selected per column. Initiate now, monitor closely, and hold or contraindicated. All right, so how are you going to answer this question? Again, you got to analyze the patient's deteriorating condition. There's that worsening respiratory distress. There's crackles, the FVC. There is also an order for BiPAP consultation, which are all identifying immediate action. Now, for each nursing action, you have to decide if it should be initiated now, monitored closely, or if it's supposed to be held, or if it's contraindicated by evaluating its alignment with the patient respiratory status and provider orders. So don't forget using the CJMM take action strategy to prioritize those interventions that will help address the hypoxemia and the respiratory muscle weakness. And don't forget evaluating outcomes to ensure monitoring aligns with the potential complications like respiratory failure. So here's the list of interventions here. The first one, it says increase oxygen to 4 liters per minute via nasal cannula. What do you think about this? You're supposed to initiate now. Why? Because this is evidence-based. It's also ordered by the medical provider to address the client's oxygenation. Remember that the patient's saturation was 92 on 2 liters, and there's also increased respiratory rate. There's that 26 cycles per minute, and these suggest early respiratory compromise in a possible myasthenic crisis. Now, another is to monitor closely. Why? Because oxygen therapy should be titrated, and continuous pulse oximetry is also needed to monitor the effectiveness. We know that overuse of O2 can reduce respiratory drive in patients at risk for carbon dioxide retention. So we definitely need to monitor closely this patient. Now, moving into the next intervention, it says administer atropine 0.5 milligram IV. The answer is contraindicated, hold, or contraindicated. Why? Because atropine is an anticholinergic. It's a medication that we use for a patient with cholinergic crisis, not myasthenic crisis. And around this time, there's no indication of muscarinic overstimulation. There's no salivation, there's no diarrhea, no bradycardia. And so administering this time would be unnecessary, and it can also worsen tachycardia. It can lead to confusion. So it's not appropriate, and this should be withheld right now. Now, next there is notify pulmonology for BiPAP initiation. Yes, we are going to initiate now because this aligns with the provider's order and the patient's current respiratory distress, and the FVC of 2.0 liters. And remember that BiPAP is non-invasive ventilatory support. This will prevent the need for the intubation. What else do we need to do here? We are going to monitor closely. Why? Because we are supposed to assess our patients carefully for airway protection. We are going to assess if there changes in their mental status, if they're able to tolerate the device, especially if they have myasthenia gravis, wherein they can have fatigue, and this can be profound as well. Next intervention, it says administer IV fluids at 100 mL per hour. What do you think about this? This is to be initiated now because hydration or mild hydration is appropriate unless contraindicated. And the patient around this time has no signs of fluid overload, and maintaining perfusion is also important here. This can also help with medication delivery and overall hemodynamic stability, particularly if the patient is in distress. Now, looking into the next intervention, administer furosemide 20 milligrams IV. This is contraindicated because the presence of crackles in the lungs upon auscultation is due to the atelectasis, not overload. And the ABGs result and the vital signs are not consistent with fluid retention. There's that normal blood pressure, the heart rate, and the partial pressure of the CO2. And if you're giving diuretics here, this can worsen hydration. It will reduce perfusion. It can also increase the risk of hypotension and some imbalances in the patient's electrolyte. Now let's move on into our next intervention. It says prepare for immediate intubation. This is contraindicated. Although the patient is in respiratory distress, but the current values, we have the saturation of 92% in their oxygen saturation, and the partial pressure of the O2 is 85, and the FVC is 2.0 liters. The patient is not yet in the critical range for intubation. So your role this time is to perform, you carry out close monitoring, and also implement the BiPAP placement. There's no need for immediate intubation here. Okay, so here's the caveat. The preparation for intubation may become necessary if there is continuation of deterioration. But right now, no, there's no need for intubation. Next, we have administered neostigmine 0.5 milligram IV. Well, this is to be contraindicated or held. We know that IV neostigmine, this is a short-acting, and this is reserved for diagnostic or emergency purposes like myasthenic versus cholinergic crisis differentiation. And the patient is already on scheduled pyridostigmine. And if you're administering neostigmine on top of that, this could precipitate cholinergic crisis. It will worsen symptoms. There's going to be increased oral secretions, increased weakness, and possibly bradycardia. So contraindicated for now. And we have encourage incentive spirometry. What do you think about this one? This is to be initiated. This is a key non-pharmacologic measure to prevent atelectasis. This will help improve lung expansion. It can also mobilize secretions, especially relevant here because the patient has crackles, there's reduced FVC, and the patient is at risk of respiratory muscle fatigue. And what we need to do here is to monitor closely because, hang on a second here, because if we are going to allow the patient to overuse the incentive spirometry, this can lead to respiratory fatigue, particularly in this case. So this patient should be using this device moderately and also being supervised. And lastly, administer albuterol via nebulizer. This is contraindicated because there's no wheezing, no bronchospasm upon auscultation. What we're only knowing is that the patient has crackles due to atelectasis. And I want you to remember that albuterol is a bronchodilator. This is indicated for COPD exacerbations or asthma, but not for atelectasis or neuromuscular respiratory weakness. And this is a necessary use, and this could cause tachycardia or anxiety as well. All right. So don't forget to take action. There's a need for us to initiate BiPAP consult. In this case, we need to increase oxygenation, also fluids and sanity spirometry as appropriate. And what we need to do is to monitor the patient's FVC, their oxygenation, their signs of fatigue, and we have to avoid those interventions that might worsen their condition, like diuretics and other unnecessary medications such as neostigmine. Now, another key here is always distinguish between myasthenic crisis, which is under medication, from the cholinergic crisis, which is caused by the over medication. And don't forget to use the objective respiratory data. We got the FVC, ABGs, the oxygen saturation to help you decide on oxygen support and readiness for possible intubation and the BiPAP use. And here, avoid unnecessary pharmacologic interventions without clear indications, right? Such as the neostigmine, atropine, furosemide, and bronchodilators. All right, let's proceed to our next test item.
Before moving ahead, I have some exciting news for you. If you are determined to pass the NCLEX within a week or a month, then your best option is to enroll in our complete online NCLEX review crash course right now. This course is a comprehensive all-in-one solution, a guaranteed shortcut, and a proven method to pass. Over the last 5 years, more than 5,000 students have successfully cleared their NCLEX exams using this course with an impressive 99% passing rate. Here's what you'll get: 100-hour animated mini crash course, ideal for those who have limited time and want to pass in just 1 week. 300-hour comprehensive recorded lectures covering 300 high-yield NCLEX topics that the exam loves to test. 5,000 real NCLEX questions, practice with actual past exam questions for better preparation. 15 full-length practice tests, including CAT simulation. Feel confident before your real exam day. Exclusive NCLEX ebook, the ultimate guide you need to pass. 1 year full access. Study anytime, anywhere at your own pace. This is a limited time offer. Enroll now to grab 70% off. Visit our website to enroll in our complete NCLEX review crash course. The link is in the description. All right, now let's dive into the topic.
We have a drop-down rational item here. It says, in the ICU at 1400 or 2 p.m., the patient is on BiPAP with vital signs, blood pressure 134/86, heart rate of 90, respirations 24 per minute, and saturation of 95%. Also, the ABGs are here. We have a pH of 7.36, partial pressure of carbon dioxide 44, partial pressure of oxygen 82, bicarbonate of 24, potassium 4.1, magnesium 1.9, and in the diagnostic results table at 2 p.m., the FVC value is at 1.8 liters, 45% predicted, and there are fine crackles bilaterally suggesting atelectasis upon long auscultation. At 2 p.m., the healthcare provider said initiate prednisone 60 milligrams daily via nasogastric tube, continue IVIG and pyridostigmine 60 milligrams every 6 hours via nasogastric tube, and monitor for respiratory failure. So in this case, I want you to thoroughly review the patient's ICU status. There's the placement of the BiPAP, the FVC number that's going down, there's crackles, and the arterial blood gases as well. And I want you to pay attention to the recent orders. We got prednisone, IVIG, pyridostigmine, in order for you to select the most appropriate action and also the right rationale for the respiratory treatment. Now, I want you to really consider the patient's worsening respiratory muscle weakness. And the patient's dependency to the BiPAP in order for you to select a correct action that will support ventilation and also a rationale that will explain its necessity. Now here, I want you to use the clinical judgment measurement model in order for you to analyze those cues and also to focus on the critical respiratory data. We got the FVC, partial pressure of CO2, and also to take action to select an intervention that prevents further deterioration to ensure that it matches the provider's intent. It says here in our instruction, you're supposed to select the appropriate nursing action and rationale to address the patient's respiratory status. So we have here the selections for the nursing action: prepare for plasmapheresis, discontinue pyridostig mean, continue BiPAP and monitor respiratory status, administer neostig mean 0.5 milligrams IV, adjust BiPAP settings to increase pressure, administer neostig mean 0.5 milligram IV, and administer low dose prednisone 20 milligrams via nasogastric tube. And we have the corresponding rational options as well. So make sure that you're going to match the rationale to the intervention that you are selecting here. Now, what do you think would be the correct action in this scenario? The answer is to continue BiPAP and monitor respiratory status. And the rationale for this is to support ventilation and prevent respiratory failure. We know that BiPAP, or known as bilevel positive airway pressure, this is a non-invasive form of ventilatory support which will help the patient improve their oxygenation. This will also reduce their work of breathing, which is very critical in myasthenia crisis. Now, in this case, the patient has worsening respiratory function, again evidenced by the declining FVC, and they also have fine crackles bilaterally, which suggests atelectasis, and the ABG result also shows some mild respiratory acidosis, right? There's that, even though it's normal 44 for the partial pressure of the CO2, but it's going in that higher direction. So it indicates the need for continued respiratory support to avoid progression to respiratory failure. Now, the provider's order to specifically monitor the respiratory failure is also aligned with the continued use of BiPAP to support the patient's ventilation. And monitoring the patient's respiratory status also help ensure that any further deterioration is promptly addressed, and it's going to make it essential to continue BiPAP and to monitor for any signs of increasing respiratory distress. Now, the other options here, such as administer neostig mean 0.5 milligram IV. I think I've already mentioned this in the previous test item. This is a cholinesterase inhibitor that enhances neuromuscular transmission by preventing the breakdown of acetylcholine at the neuromuscular junction, which can be helpful in myasthenic crisis. However, in this case, the patient is already receiving the pyridostig mean 60 milligram via nasogastric tube, right? Every 6 hours. Now, if you are going to add the neostig mean, this can increase the risk of cholinergic crisis, which is characterized by excessive muscarinic stimulation. They're going to end up with bradycardia, diarrhea, excessive salivation, and so you don't administer this extra drug. What else? If you selected prepare for plasmapheresis, the rationale for that is to remove autoantibodies in severe myasthenia gravis exacerbation. Now, I want you to know that plasmapheresis is therapeutic option for a severe myasthenic crisis when the other treatments have already failed, such as the IVIG, or whenever there is significant respiratory compromise. Now, again, this patient is getting IVIG therapy, which is actually ongoing, and this is considered standard first-line treatment for myasthenic crisis. And the reason for the IVIG is to help neutralize the autoantibodies that attack the neuromuscular junction, and the plasmapheresis would typically be considered if there is no improvement after the IVIG. All right. Now, what else do we have here? We have discontinue pyridostigmine. The rationale to reduce the risk of cholinergic crisis during steroid therapy. Now, I want you to remember that pyridostigmine 60 milligrams every 6 hours per nasogastric tube was specifically ordered, and that is the mainstay treatment for this patient in crisis. Again, it is intended to improve neuromuscular transmission, right? And the patient has no indication of cholinergic crisis, so we are not going to discontinue, right? Now let's get into the next section here. Adjust BiPAP settings to increase pressure. The rationale for that is to improve oxygenation in response to low partial pressure of oxygen. Now, here's the thing. Adjusting the BiPAP settings requires input from the pulmonology or pulmonologists and other specialists, because there's going to be more people that will oversee this patient, such as the respiratory therapist. So this is nothing that you can do as an independent action. You're not going to be adjusting the BiPAP settings. Usually it's the RT who will be doing that. And the settings are going to be titrated based on this specific parameters, such as the patient's blood gas results, and any changes to the settings should be done by the right person. Now, what else do we have here? Administer low dose prednisone 25 or 20 milligrams via nasogastric tube. Now, I want you to go back into the healthcare provider orders that there is already a entry of prednisone 60 milligrams daily via nasogastric tube, right? And this is a high dose, which is appropriate for reducing the inflammation. It can help manage the autoimmune aspect of the myasthenia gravis. Now, if you are going to reduce the dose to 20 milligrams without an order, is not appropriate, and it could delay the patient's recovery. It can lead to inadequate immunosuppressive effects. Now, I want you to pay attention here that the goal of prednisone therapy is to treat the underlying autoimmune response, and this action would be considered a medication error. So avoid doing that. Now, for a patient in myasthenic crisis, your primary focus should be to support the respiratory function and to prevent respiratory failure. And also the correct course of action is to continue the BiPAP and monitor the respiratory status, because this is aligned with the provider's orders and also supports ventilation. And other interventions like administering neostigmine, adjusting the BiPAP settings, or discontinuing the pyridostigmine are either contraindicated or premature based on the patient's current condition. Now, it is very critical for you to follow the provider's orders here and carefully consider the patient's clinical presentation, and also to avoid premature interventions that may worsen the patient's condition. Let's get into our next test item. We have a highlight in text item. So we have a reference here for healthcare provider orders at 2 p.m. that said, start prednisone 60 milligrams daily via nasogastric tube, continue IVIG and pyridostigmine 60 milligrams every 6 hours via nasogastric tube, and monitor for respiratory failure. And for the diagnostic test, I believe this was already mentioned regarding pulmonary function tests and lung auscultation. So your task here is to highlight the findings in the nurse's practice notes requiring immediate nursing action, and to select only those indicating urgent intervention. Now, pay attention to the progress notes for the ICU department. It said, In ICU, patient on BiPAP reports persistent fatigue, difficulty swallowing, and anxiety about breathing difficulty. Husband expresses concern about intubation risks. Vital signs: blood pressure 134/86, heart rate 90, respirations 24, saturation 95 on BiPAP. Lung auscultation reveals fine crackles bilaterally, FVC 1.8. ABG 7.36 on the pH, partial pressure of carbon dioxide 44, PaO2 82. Patient exhibits increased bilateral ptosis, new facial muscle weakness, and speech increasingly slurred. Grip strength reduced to 2/5 bilaterally. Oxygen saturation drops to 93% briefly when BiPAP mask is adjusted. Patient reports new chest tightness and mild headache. Skin is diaphoretic. Patient remains alert. So here, I want you to carefully read the progress notes and highlight only those findings that require immediate nursing action. You got to distinguish if the manifestations are urgent, and also don't forget to use the CJMM to help recognize the cues to strategize in pinpointing those objective data. All right, so what do you think would be the correct answers here? One of those is the FVC 1.8, 45% predicted, right? We know that the FVC is a measure of respiratory muscle strength, and a value of 1.8, which is equivalent to 45% of the predicted normal value. This is indicating that there is significant respiratory muscle weakness. Another, that this is a critical finding because it suggests that the patient's ability to ventilate effectively is severely compromised. This is putting them high risk for respiratory failure. Now, another thing is the respiratory rate of 24 cycles per minute. This is elevated, also suggests that the patient may be experiencing increased work of breathing, which indicates respiratory distress. And remember, in myasthenia crisis, when there is muscle weakness worsening, the patient's ability to take adequate breaths will diminish. So this can lead to compensatory tachypnea, and the body will try to improve oxygenation, but it's not going to be helpful. So this finding also signals that the patient's respiratory status is deteriorating. So you need to intervene on this one. Now, another phrase that you should be highlighting is the oxygen saturation of 95% on BiPAP. This is borderline and should raise concern in the context of myasthenic crisis. So imagine that the saturation is only 95 and she's already on BiPAP, right? We know that this is a non-invasive respiratory support system that will help increase the patient's ventilation, but it's not always effective, especially if the respiratory muscles weaken further. Now, what else do we have here? The saturation of actually the fine crackles, right? So these are signs of atelectasis, right? When the nerves auscultated. So this is lung collapse, especially the smaller airways and the alveoli. And this is happening because of the impaired respiratory muscle function and also reduced ventilation during the crisis. And this is a significant sign of worsening gas exchange, and this should be addressed immediately to ensure that the lungs are being adequately ventilated. Now, what else? I want you to highlight this. Oxygen saturation drops to 93%. And that continues briefly when BiPAP mask is adjusted. So the brief drop of the O2 saturation indicates that the patient may have a reduced respiratory reserve. So they are now dependent on the BiPAP, right? So the patient should be continuously using this device and make sure that we are monitoring this patient because they might get confused. They might start taking off the mask at this point. Now, what else do we need to highlight? We have new onset of facial muscle weakness. This is also a critical finding in myasthenic crisis because this is a reflection that there is bulbar involvement, which is associated with airway compromise. Now, if you're wondering what bulbar symptoms are, this actually includes facial weakness. There's going to be impairment in the patient's ability to swallow. They're not going to be able to protect their airway properly. So this is going to increase aspiration risk in this patient. This will compromise their respiratory function. So this is considered an urgent finding because we are dealing with the airway. All right, what else? We are going to select speech increasingly slurred, which is a classic sign of worsening bulbar weakness in the myasthenic crisis. So this indicates that there is now impaired neuromuscular function in the muscles responsible for speech. And this is a huge warning sign that the patient's ability to manage their airway is at risk, right? Now, this is also going to suggest that there is progressive weakness of the facial, the throat muscles, and again, will increase their risk of airway obstruction and aspiration. They can choke and aspirate. Now, what else? There's also new chest tightness. Why? Because this can indicate respiratory fatigue or cardiac strain. Then this is concerning because it could signify impending respiratory failure or maybe cardiac involvement, which is caused by the stress of the myasthenia crisis. Now, this also requires immediate evaluation, including the assessment of the patient's respiratory status and cardiovascular system to determine if there's a need for further intervention, maybe a need to adjust the BiPAP setting. And so the rest of the options or words here are not highlighted. If you specifically highlighted persistent fatigue in the first sentence, this is incorrect because fatigue is a chronic symptom of myasthenia gravis, and it's typically not an immediate cause for intervention unless it's significantly worsened. And don't get me wrong, this is important to address, but it's not going to require urgent action in this context. Now, if you selected difficulty swallowing, which is dysphagia, it is also a common symptom of myasthenic crisis, especially with bulbar weakness. And remember that this was already acknowledged when the patient was in the ED, right? That is why she ended up getting the nasogastric tube insertion. And it also requires monitoring, but does not really necessitate immediate intervention unless there's any signs of aspiration or airway compromise being observed. Now, if you might selected increased bilateral ptosis, all right, patient exhibits increased bilateral ptosis. That's right after the ABGs. We know that the drooping of the eyelids are a hallmark symptom of myasthenia gravis, and this can worsen during a crisis. However, in this scenario, ptosis is not a new finding. It was a historical data, and it does not require immediate intervention unless it leads to another set of symptoms such as airway obstruction or difficulty swallowing. Another is anxiety about breathing difficulty, and this is on the first sentence. We know that anxiety is common in patients experiencing the respiratory distress or myasthenic crisis. However, this is a psychosocial concern that should address after you have stabilized the physical needs of this patient, right? You have to address the physical needs first. Now, another is husband expresses concern about intubation risk. This is also valid. Again, falls into the psychosocial category and should be addressed after the patient's physical needs have been prioritized. Now, what about the mild headache here? This is on the second sentence towards the end of the case scenario or the paragraph. This is a non-specific symptom that could be related to the IVIG therapy or maybe other factors, but it doesn't indicate immediate deterioration of the patient's myasthenic crisis. It is not urgent in this context unless it worsens or is accompanied by other neuro changes. Now, if you selected skin is Diaphoretic, well, excessive sweating can be caused by so many factors, including anxiety or maybe pain, or the body's response to the respiratory distress. While concerning, diaphoresis alone is non-specific, and it does not indicate life-threatening change in this patient's case. And of course, patient remains alert, nothing bad about it, so we're going to disregard that one. All right, let's move forward to our next test item.
Before we move ahead, here's something you shouldn't miss. If your goal is to pass the NCLEX in just 1 week or 1 month, then the fastest and most effective way is to enroll in our complete online NCLEX review crash course. This course is a one-stop solution, a reliable shortcut, and a proven method with a solid 99% passing rate. More than 5,000 students have successfully passed the NCLEX by using this course. Here's exactly what you'll get. 100-hour mini crash course perfect for those who want to pass within a week. 300-hour comprehensive lectures covering 300 essential NCLEX topics that are commonly tested. 5,000 real NCLEX questions. Prepare with real exam questions and eliminate surprises. 15 full practice tests, including CAT simulations, simulate the real exam for a stress-free experience. Exclusive ebook plus 1-year access. Study whenever and wherever you want. Seats are filling up quickly. Enroll now to save 70%. Visit our website to enroll in our complete NCLEX review crash course. The link is in the description. Now, let's continue with the topic.
Our last one. We have a bow tie. It says here, patient is in the ICU at 2 p.m. with myasthenic crisis on BiPAP, receiving IV immunoglobulin, pyridostigmine, and newly started prednisone. So the progress notes in the ICU, I'm not going to repeat that because I already mentioned these. Also, the healthcare providers at 2 p.m. are stuff that I already mentioned. And the same thing with the diagnostic results at 2 p.m., such as the PFT, FVC, and the lung auscultation. So let's move right along into the instructions here. It says drag and drop the options into the appropriate sections of the bow tie diagram. Select one potential complication, 2 actions to take, and 2 parameters to monitor. So the options for the potential complications are steroid-induced exacerbation, cholinergic crisis, impending respiratory failure, aspiration pneumonia, pulmonary edema. So what do you think would be the best answer here? The answer is impending respiratory failure, because the findings that we are seeing in the nurse's notes, the lab values, the diagnostic tests suggest significant distress. Go back into the diagnostic test. The FVC is down to 1.8 liters, and the oxygen saturation is only 95 while the patient is on BiPAP, and there's also presence of crackles bilaterally, and these all point to severe respiratory muscle weakness. Now, this is also compounded by a partial pressure of the CO2 of 44, even though it looks normal, but this indicates a potential for respiratory acidosis, which will further suggest respiratory insufficiency. Now, the incorrect options, such as cholinergic crisis, we're not picking that because there's no evidence of pyridostigmine overdose. There's no salivation, there's no bradycardia or diarrhea. And for pulmonary edema, we're not going to pick this one because the lung crackles are likely related to the atelectasis rather than pulmonary edema, because there are no other signs such as jugular venous distension, no frothy sputum to suggest fluid overload. Now, if you selected aspiration pneumonia, this is also incorrect because there's no evidence of an infection, no fever, no purulent sputum, and the patient's dysphagia is being managed with a nasogastric tube, and so aspiration pneumonia is not a primary concern at this moment. Now, if you selected steroid-induced exacerbation, although prednisone has been initiated here, the patient has not yet shown signs of steroid-induced exacerbation, like rapid worsening of the symptoms. So we are not picking that. For the 2 nursing actions, the choices are initiate nasogastric suctioning, administer furosemide 20 milligrams IV, ensure proper BiPAP mask fit and continuous use, administer antibiotics for suspected infection, and notify the intensivist of FVC decline to 1.8 liters and provide reassurance to reduce anxiety. Now, let's take a look into the answers here. The first one we have is ensure proper BiPAP mask fit and continuous use, right? Because with the BiPAP, we want to make sure that they're able to maintain oxygenation and ventilation, especially during this crisis. So if you are promoting proper mask fit, this is going to prevent air leakage, and also continuous use would ensure that the patient maintains adequate ventilation. And the fact that the patient has already desaturated to 93 briefly when there was adjustment of the mask. Another answer we have is to notify the intensivist of the FVC decline to 1.8 liters. So this is a critical threshold of the myasthenic crisis. It reflects that there is now severe weakening of the respiratory muscles, which require possible intubation and maybe advanced ventilation support. Now let's move to the next set of boxes here for the parameters to monitor. The options are blood glucose levels, forced vital capacity or FVC, jugular venous distension, arterial blood gas results, salivation and sweating, and patient's anxiety levels. What do you think about this? Well, the answers are the following. We are going to monitor for the FVC. This is very critical to identify if there is a need to escalate the care or if there is a need for us to intubate this patient. And there is also a need for us to communicate rapidly if there is going to be a significant change in order that we are not allowing the lung collapse to occur. Now, what else do we need to select? We have arterial blood gases. Obviously, there was already minor changes in the arterial blood gases, and this is very important for us to make sure that we are monitoring the values because the patient's PaCO2 is already 44, even though it's normal. Again, it suggests that the patient is not effectively eliminating carbon dioxide, a possible sign of respiratory compromise. And so the others, we have blood glucose levels. That's not really going to be important here, even though prednisone can cause hyperglycemia, but this is not the immediate priority in the context of respiratory failure. If you select a jugular venous distension, this is intended to check for any fluid overload, but the patient doesn't have any signs of pulmonary involvement or no signs of any fluid overload, I should say. Now, what about salivation and sweating? These are signs of cholinergic crisis or possibly caused by the overdose of pyridostigmine. But in the current scenario, the patient does not exhibit any signs of cholinergic crisis. All right, so these are not relevant. And lastly, patient's anxiety. Very important to address, but not a priority over assessing and also managing the patient's respiratory function. And so your focus should be on ensuring the adequate ventilation and also to prevent respiratory failure, not simply addressing the anxiety at this point. All right, so you've completed the bow tie, and I hope that you're able to select the correct answers. So that's the end of our review today. We hope that this session boosted your understanding of managing the complex patient cases and tackling the NGN test items. I want you to keep practicing so you'll be ready to shine on the NCLEX. And don't forget to subscribe to our YouTube channel for more NCLEX prep content, and also give this video a thumbs up and share it with your study buddies. I'll see you in the next review session. Thank you for watching.